Good afternoon, everybody. Thanks for coming to this Dean's Lecture, and we're here to celebrate the promotion of David Peters to the rank of professor at our school. And nice that your family could be here. So, and as I say many times, the decision to be promoted to professor is not made by the school. It's not made by the chair or me or the A&P committee. It's really made by peers from around the world who evaluate your achievements in your career and pass those decisions on to us. And so it's an honor not just bestowed by us but by your peers. And to come on this faculty, it's not easy. You know the intense criteria we use to bring people on, but then to rise to this rank, it really is a remarkable achievement. And it's always odd when I introduce the person who's going to speak, because many of the people in the room have worked with them. They're here because they know him really well, and they know him far more than I do. But I have had the opportunity to do some things with David, so I know him a little bit. I mean, I think I know, like you, he's a Canadian, he's a hockey fan, and we went down to the Department of Defense one day. Do you remember that too? Because the DOD had decided they wanted to help us in Afghanistan. And the kinds of help they wanted to give us was that we could ride around on military convoys to collect data and do things. And we said, thanks, but no, with that kind of help we don't need. So we have done some things together. But let me just tell you a little bit about David. He had 2 undergraduate majors, so probably not many people know this, but one of them was religious studies. So his undergraduate degree is in religion, and he had a dual major in chemistry. And how they mixed together, I'm not sure. And then he went. That was at Winnipeg. He went to the University of Manitoba, where he got his Bachelor of Science and Doctor of Medicine, and then was in practice for a year, where he had responsibility for First Peoples and health, and then came here and got his Master's of Public Health degree in 1989, and then his DrPH in 1993. And then, as probably everybody also knows, David went to the World Bank, where he demonstrated exceptional leadership and innovative leadership. And one of the things that he did there was develop the SWAPs, the sector-wide approaches, to aid and work with a whole host of countries. And when your letters came in about your promotion, this is one of the points people made about how you had developed this innovative program that rethought about how donor countries give out aids. So David's passion is health systems and how to improve health systems. And as I found out when one day the students asked me to debate about something about healthcare in India, so I went to debate, and I was debating David, and I didn't realize he had lived in New Delhi, and that he always carried a copy of the Indian Constitution around and quoted from it during the debate. So, but also had it was really a nice time for me, that debate. So, but right now, his research is focusing on health systems performance in low-income countries, and understanding how health systems improve health status, and how poverty affects health expenditures, and how risk of ill health and expenditures affect poverty. And as we'll probably hear about, I think we'll hear about the work in Afghanistan. So I could go on and on, but just to say that David's a member of Delta Omega. He's now I'll get your title wrong, but basically heads the Division of Health Systems in the Department of International Health, and in that role is an associate chair. So David, we're here to congratulate you on this achievement and look forward to hearing your talk.
Well, thanks very much for that overly kind introduction. I'd like to really talk about planning and results and evidence, but really I'm going to be talking about how lucky I've been and how fortunate I've been to be here and to work with great colleagues on interesting types of work. as one of the things that's important is understanding initiating conditions. And I have to say I've been very lucky that, if my grandparents hadn't jumped out from this farm in Russia, my grandfather hadn't gotten out of this prison in Moscow and taken this boat to come to Canada, I would not have been able to have the very productive youth that I did have. And then come to study here at Hopkins and work at the World Bank, and then end up working at Hopkins and lose all my basketball skills, but still be able to travel around the world working on interesting and important things. And just in case, you lose the plot before we get to the end, this is what I'd like to at least say what I think I've learned. And one of these is really around pragmatism. Pragmatism really as a way of inquiry in health systems research. And then pragmatism in terms of what it's applied for. And if your interest is in improving people's health, what I think we need is a continuous way to find out different strategies of being able to do that, as well as continuous ways of understanding how these strategies work. And one of the approaches is to, first of all, build on the best evidence that we can get, but you need to adapt and learn along the way and really focus on the implementation towards sustainable systems. And as in our department, we're concerned about really the health of disadvantaged. What I think I've learned is it helps to be able to say that clearly that that's what you intend to do, to focus on health of disadvantaged, to be able then to engage with disadvantaged groups and people, be able also to help them facilitate experimentation, but be able to measure and disclose and learn along the way. So if all else is lost, hopefully we can come back to this at some point on the way. So I came here as a fresh medical graduate, trying to with my wife, and tried to learn things in epidemiology. And we were largely trained in these. These are actually my books in epidemiology and certain logic around Karl Popper. But we also got these quasi-experimental designs, and we're guided by Carl Taylor and team around the Naringwall experiment of health services and linking nutrition and health. We had a Dean D.A. Henderson who told us how he's able to eradicate smallpox through good management, research, and being able to have political commitment. And we were all excited about the child survival revolution and the Moseley-Chen framework for understanding that. And with that, I was set off to do the quest that we all had here, which was to find sustainable solutions to improving the health of disadvantaged people. And one of my first opportunities as a student was to go to the Gambia and work on really trying to develop algorithms around pneumonia, and trying to be able to diagnose simple in the cases of pneumonia, which would lead then later to the integrated management of childhood illness. I don't know who this guy here is in the red, but the thin guy anyway. But what we found was that, yes, people could learn an algorithm with some sensitivity and specificity, and that they could do it on video and in training. But of course, when they had to do it in practice, things didn't work out quite so well. But it was very exciting to be part of an initiative that was really around trying to improve kids' lives. I then moved to a big project in Cebu, the Philippines, and had some great mentors, Stan Becker, Ron Gray, and Bob Black, and learned a lot more about planning. This was in the context of a mortality and surveillance system to try and evaluate a pneumonia and diarrhea control program. The only problem was that they didn't implement the pneumonia control program at all, and the diarrhea control program was only half implemented. And so when we showed the results that actually seeing people wasn't very good, you actually got sicker, we weren't too pleased. But we did do some really quite innovative work in terms of assessing the quality of care. So we shouldn't have been surprised, because the quality of care was so poor both in public and private sector that there wasn't much of an effect. The other planning lesson I had from this was I was originally going to do my doctoral dissertation in the Philippines looking at linkage between pneumonia and, measles, pneumonia, and diarrhea. And unfortunately, the blood samples got destroyed on the way back, and so I had to do a completely different study, and I'm sure Neil Halsey is relieved that I didn't become an infectious disease epidemiologist, but instead moved to Sri Lanka, where Carl Taylor and Bill Renke had a project looking at really the problem of how is Sri Lanka able to have such low infant mortality when they still had such high levels of malnutrition. and Tim Baker was also my dissertation advisor then. And we tried to find out whether this was true. We actually did a census in in a large part of the center of the country, and we looked at midwife records and hospital records and civil registration and tried to find out whether it was true. And it was true that, in fact, their mortality was around 19, which that time was slightly better than Washington, D.C. They did have high levels of low birth weight, but they also had, high levels of institutional delivery, over 95% about, and high levels of postnatal care, over 90%. And in fact, not having postnatal care was the biggest risk to having infant mortality. But the girls actually were able to have catch-up growth in the first couple of years. The guys not so much, but it happened. And here you see a kid who's clearly not a problem with undernutrition. So from there, I moved to the World Bank and had lots of fun on different types of projects, largely in Africa. But we also had access to a lot of data, which was a lot of fun. So what we did here was try to get data across Africa on health services, expenditures, and health outcomes. And what this graph here is, this is a box plot, so I like to use my, the basic biostats we were told. And these are box plots of countries showing, what their the range of DPT-3 immunization was over time. And what you can see is the median here was the growing increase. 1990 was the year of universal childhood immunization. So everything peaked then. We didn't quite achieve universality, which was, for some reason, 80%, I believe. But then after that, it reduced quite a bit. But you could see from this large campaign that it was really quite successful, even if some of the figures were being fudged. However, at the same time, there was a problem that we were finding in terms of mortality. Now, this is a similar box plot. This is now female mortality rates over time in 5-year groups. And what we found is, lower is better. You don't want to die. And so we found that over the 60s to the 90s, there was an increasing trend of reducing female adult mortality, and then a change in 1995 as it started to increase. And I think this was one of the first times we saw huge demographic shifts. And of course, this is because of the HIV epidemic. And so we were wondering about, the problems that were raised about being able to focus on one kind of intervention at a time, and yet losing some big picture types of problems affecting health. I did work on a lot of projects. Many of them were actually quite successful. But, in dealing or working with ministries of health, realized what kind of problems we were adding to that, we were giving them in terms of, so many different projects, a lot of them duplicating things, a lot of them really fragmenting them, because each one of them had to get their own staff, their own reporting system, their own financing, and they're often quite inflexible and really detailed, over-designed. I inherited one project in Ghana that had 16 legal covenants that were already passed because they were all dated. So I spent way too much time with the lawyer than I did in terms of, instead of working on health programs. And this is one of the problems that we had, and also their lack of sustainability. So that really led us to different ways of planning, and I was lucky enough to be working on planning in a number of places at at the state and national level in a number of countries, and on particular projects. Now, my wife told me not to go into details of how none of these plans actually work out, so I won't. But actually some of them were relatively successful. But one of the things that we tried to do is what Mike was referring to, was a different way of doing business, the sector-wide approach. Really to try and put some coherence into the way governments were able to deal with donors. We were putting some order around their health sector. And so this actually is the first published article about the sector-wide approach. It was first labeled that in 1997. And what it is was really an idea of having a partnership led by a Ministry of Health with the purpose of improving people's health, and having a program of work which involves, one strategy, a national policy and strategy, a set of expenditure frameworks, and introducing common management arrangement, and usually some kind of institutional reform, and always some way of measuring progress against a select number of indicators over time. And that was really the nut, the kernel of what was involved with the sector-wide approach. Now, this was taken up by a number of countries. I got to work on several of them, Ghana probably being the most known, but several other countries as well. And then 10 years later, I was asked to evaluate, well, what actually happened to this? What I'm doing here is showing just one figure from basically showing under 5 mortality. They had about 20 indicators that they followed. one of the key objectives was to reduce mortality among the poor, and child mortality was the measure. So what this figure does is we pulled together 5 demographic health surveys, and what you see here is a trend, this group being the poorest 40%, the middle 40%, and the richest one. And you can see that there actually was a statistically significant decline. And so at one level they were able to claim success. On the other hand, it wasn't nearly as much as they would have liked, especially since they had doubled salaries of health workers over this time. Health services had increased, but there was really kind of a mixed picture, and certainly a lot of surprises along the way, such as the introduction of a new health insurance scheme and continuing issues with the Ghana Health Service. Recently, we were asked to look back on what's happened with sector-wide approaches, and we can see that actually it's become quite widespread. This is a paper currently under review, but it's spread to probably about 30 countries have tried to use this approach. Every swap, every country is different. They have their own policies they pursue. That's not all cookie cutter. But what we did find is, compared to other countries, they're much more likely to actually measure progress. The problem is that progress is often mixed. It's not universally improving. So some services will improve, others will get worse. The other aspect is an interesting international-national type of dilemma, and that swaps have clearly led to consensus-building processes, policy processes within country. But internationally, they were seen as really not addressing priorities, particularly the HIV epidemic, not addressing that, as well as other global health initiatives around vaccines or malaria, TB, and other big programs. And so what happened over the years was trying to manage both donors pushing international programs and people within country pushing international programs, and this other type of consensus building approach. And now what's happened is these global health initiatives are in a position of trying to find ways of, well, how do you sustain? Many of them have had big successes. How do you sustain them, keep them going? And ironically, it's now at this stage where global health initiatives more than ever are needing to actually incorporate SWAP principles as they try to integrate into national systems. Moving gears a bit, we were lucky. By this time I had 2 kids, and we were able to move to India, and I was given the chance to not only work on projects but also to do what became the largest analytic work in the bank in terms of a country study. And what we had here was we had to really design a question of how do you improve health systems for the poor in India. And at the time, there were sort of these, untouchable ideas that you couldn't touch. Well, first one being that, that India, the public sector was really there to serve the poor and disadvantaged, and that's what they were doing. And you see Gandhi and Ambedkar, the champions of the poor. So that was something that was just assumed. The private sector was something they didn't want to talk about, even though this was a country that was liberalizing and growing economically largely through private sector growth. And health reform was certainly not on the table, because that's something that you did in the Americas and Europe. This is back in the mid-90s. So, of course, this is exactly what we did. We tried to address these 3 issues. We engaged about, I think, 11 or 12 institutions in the country with the national, state governments, and NGOs, and actually ended up later writing a piece of there, as you can see, with people from government and other agencies. But the first sacred cow was this notion that they're actually reaching the poor. So what we did was, using national surveys and data around expenditures, looked at, well, who actually benefits from the public subsidy in health? What you see here is the richest 20% were getting 33% of the public spending on health, and the poorest 20% were getting 11%, so threefold different. And if it were perfectly equal across, it would be 20%. But as you can see, it was clearly pro-rich in distribution. So we were not winning friends here, but it was, except for a few that wanted to pick this up. We showed this in many different ways. Looking at institutional delivery, here you see in blue the public sector distribution. Who got an institutional delivery among the richest 20%, the poorest 20%? Burgundy being the private sector, so you can see that the disparities are even greater when you include the private sector. So really problems in terms of being able to reach the poor. This is a concentration curve, basically looking at different types of health services and which is more pro-poor and pro-rich. I guess all you really need to think about is this equity line is red. If you're above the line, more of the poor are getting it relatively. If you're below the line, more of the rich are getting it. And really what we showed is the problem was with hospital services, and that was skewing their expenditures towards the rich. The other problem with hospitalization is that people were actually going into poverty because of going to hospital. They're having to pay for hospitalization in both public and private sector. About a quarter of people hospitalized would fall into poverty just as a result of paying for care. So we needed to do something differently. The second pillar or the second problem was really looking at private sector. And what we demonstrated, again, using national data that should have been analyzed before, but was basically that outpatient and hospital care were, for the most part, in the private sector, the burgundy. Most of it was in the private sector. Much of it unregulated, poor quality outpatient care, but mostly in the private sector. And immunizations, antenatal care, for the most part, in the public sector. They knew very little about the private sector. It was almost a willful negligence. And one of the things we did was a survey of them in Uttar Pradesh. And here you saw just sort of things that they would admit to doing in terms of kickbacks and getting getting free drug samples. I guess a lot of people do that, getting paid for referrals. But basically you saw these private providers, both traditional and untrained providers, that were well embedded in market systems in India, and a big part of basically where poor people get their care. The other problem was and remains total reliance on private sector funding and paying for out-of-pocket care. And it was over 80% of payment was really private payment, and being out-of-pocket really vulnerable to health risks, as you can see. So one way of showing this internationally was saying, well, what percent of your public spending on health, I shouldn't say public health expenditure after David Deshai's talk of saying what public health really is, but public expenditure of health, what proportion is actually going, of total government expenditure, what proportion is going to health? And here we saw India really here among the low levels. There's the United States for comparison. This was about 1% of GDP was spent on health in India, which was very low. And this may be hard for you to believe, but at the World Bank, in every country that I worked on, we were actually encouraging government to spend more on health in the public sector, also to actually take away or to at least provide provisions for user fees. But again, that's not often known about what we do. But in India, it was a clear case, total underinvestment. The other aspect was really needing to look forward to changes in disease status. So here you see a graph looking at different causes of disease, and the big change here is non-communicable diseases rising from 41 to 49% in less than a decade, and with really gaps in programming for those kind of issues in India at the time. So not stopping there, we sort of set out an agenda for reform, which we weren't supposed to do, but we're able to do anyway, involving being able to really oversee the health sector better and making it more pro-poor and client-friendly, actually dealing with the private sector, both harnessing opportunities and trying to counteract some of the market failures, trying to develop a financing system that makes sense, i.e. insurance, and being able to have programs that address the health transition and improving on quality and accountability. Okay, so with that I came back to Hopkins. I did not learn Latin, by the way, but I think that just means not everything is what it appears, more or less. But along the way, I had to think of how do I want to do health systems research now that I'm coming to Hopkins? And I had my training in those sort of post-positivist types of approaches, and I had some influence from these kind of things from structure of scientific revolutions that said, well, you really need to think of other paradigms and that how change is made. And the book of Mismeasure of Man really demonstrated, well, how easy it is to screw up when you measure or mismeasure, and that you can't confuse reality with what you measure. So let me ask, how many of you know who this person here is? This is a Hopkins graduate. A Hopkins professor at one time. Non-tenured, by the way. So I didn't know till a few years ago. This is Charles Peirce. This is actually the guy who coined the term and developed the philosophy and the logic models around pragmatism. And he was the professor of John Dewey, who later popularized it along with others, William James. I only connected the dots recently in the last couple years. But it's scandalous how he didn't get tenure, by the way, but we don't need to get into that.
Not in our school.
No, he was at the, we weren't here yet, no. Right. Yeah. No. Well, I'll tell you the story later. But anyways, in terms of a way of inquiry, it was a good middle ground between sort of the post-positive approach and an area that I really wasn't that well versed in terms of naturalist or constructivist types of inquiry, qualitative research, which I came to really appreciate its power during work in Sierra Leone in terms of how it was able to influence decision making. So in terms of thinking of it as a pragmatic, of an inquiry for health systems research, I think it fit together because, again, not just because it's in the middle. There's an old joke about Canadians, why did the Canadian cross the street to get to the middle? But that's not, so maybe there's some, something inherited that way. But really, in terms of the way you think about knowledge, between the researcher and your subject, the way you think about the role of values, the logic processes in terms of using multiple processes fit with what I thought had to be done in health systems research, and leading ultimately to, mixed methodologies in both quantitative and qualitative. The point being is that many of people were successful because they know a particular paradigm or a particular method. But for health systems research, it's really around addressing the question and then trying to get the methods to give a full understanding and a full picture for that. And one of the biggest challenges coming back was this question of how to achieve the Millennium Development Goals, the MDGs. 3 of which are around trying to reduce, or around health, trying to reduce child mortality, trying to reduce maternal mortality, and improve or combat HIV, malaria, and other diseases. And they set common targets for these and for certain conditions with having to deal with them, and then set off in sort of how do you go about doing this. Well, the dominant way of thinking for how to address these things was pretty linear. You choose the right set of health interventions, which usually means it's cost effective and addressing a big burden of disease. Then you set ambitious common targets, i.e. Millennium Development Goals. You fund them adequately, certainly facilitated by the MDGs. And then this is where the problems lie. You just implement them as designed. And you spend a lot of time planning and detailed planning, and it just, well, in my experience, doesn't work that way. We've done a lot of work here and elsewhere around trying to find cost-effective solutions in the disease control project. Some of the editors are here, and contributors and authors are here. Really done a good job in showing what can work. And then at the same time, we have this challenge of, well, why can't health systems deliver this consistently at a large scale and to vulnerable populations? And it really comes a lot down to this question of implementation and how do you do that. So I had the opportunity while here and while moonlighting at the World Bank, I guess, to bring together people to work on this question of really trying to synthesize knowledge around how do you improve implementation in low and middle income countries, which strategies work, and how do you get strategies to work consistently for the benefit of the poor in real world settings. And I'm not going to give you all the studies and results, but we started off with a series of inquiry around what works, which were basically systematic reviews. And once you get over 100,000 articles that you're screening, I think you really get bored with this technique, by the way. But anyways, we did systematic reviews on service strengthening and community empowerment and health worker performance and organizational performance, and a number of other things, trying to use models with longitudinal data over time, doing sort of synthetic evaluations, and then trying to do institutional analysis and country case studies. And I'm just going to show you a few results so you don't, well, just a few of these things. So I wanted to come back to that question of immunization, and here's DPT-3 immunization, because there was a target for 90% that has to be there. And what I'm showing here is each line represents a country over time. It's linear, which is not quite, it's just the model we're using, but each country gets its own slope and its own intercept. And what we looked at here, when you saw the box plot and those edges, that's really sort of the 95% confidence interval of countries as they improve. And what you see here is that, this is a bit like pickup sticks, but there really is no average country. Nobody follows the same kind of rate of change. And where you start off matters. There may be a group of countries that start off well and stay well, but basically every country follows its own slope. When we looked later at what happens with the MDG against trying to reduce child mortality, where the target is that everyone should reduce it by 2/3, which is about 4% or 4.3% a year. Each country is again shown by a line, and what you see again is that there's different rates of change, different starting points matter, and that basically each country follows its own pathway. So the notion of a common pathway, a common target, really doesn't follow what's happened in the past, and not sure it will in the future either. We also looked at what happened in terms of reaching targets for some of the MDG services, and regrettably, it was only between a half and a third, and I guess some of you will be working on models that will update this and do this in a more sophisticated way. We tried to find particular interventions that worked in terms of implementation, and of course there's a lot of successes, but we didn't identify any particular intervention itself as being the guarantee of success, of implementation. Rather, what mattered was how did you implement. So here's some of the results from the community empowerment assessment, that really you had a greater likelihood of succeeding, of getting good implementation outcomes, so a change in outcomes with the comparison, when you had community coordination, when you had local adaptation, when you were consulting also with powerful groups, and you had flexibility built in to your programming. And these were, so how you implement something actually matters as much in terms of implementation success as what you choose to do. And looking across all of these methods and studies, there are a number of common findings. First of all, that implementation faults are common. They happen all the time. There's a lot of strategies to deal with this, and many of them succeed. It's just that a strategy in one place, even with the same label, doesn't necessarily mean the same thing's going to happen somewhere else. If that strategy is to take away user fees, or if it's to start contracting, they're in no way the same place from country to country. Policymakers often define strategies, but they don't get implemented. They have very relatively little influence on what actually gets implemented, and there's lots of unintended consequences, usually bad, but sometimes good things that happen. But unfortunately, one of the things that we did find consistently was that there's very little attention in the literature on really demonstrating how to improve implementation of services to the poor, that the empiric basis for this is actually quite small. In terms of what does work, though, in addition to things around community empowerment, it's about identifying and minimizing constraints. Mobilizing resources is a bit of a no-brainer, but it's generally, it's not that you don't need money, but it's certainly part of it. What we did find was that actually as you added components to a strategy, you were more likely to have a bigger effect. However, the risk of failure was also bigger when you had multiple component strategies. And one of the big questions then is, well, how do you actually merge all these different disease control programs? And what we found was that although you could certainly scale up within a disease control program, that success in a program in a small area could certainly be scaled up within a country, there was really no consistent evidence as to whether success in one program would contribute to success in another or take it away because they competed against each other. The results are still quite mixed on that, and it's also an area of continuing concern. So the practical implications from this work is that there is no silver bullet. I'm afraid there's no vitamin A pill that will make implementation work, but there are some successful approaches. Part of it is learning by doing, and part of that involves having flexible planning, using data, and involving key stakeholders. So I want to discuss a bit about Afghanistan and how we've tried to apply this in terms of rebuilding the health sector, using information for that. So this was the first national scorecard on health services that we developed in Afghanistan, and it involves about 600 health facilities every year that we survey. We do about 6,000 provider-patient interactions and patient exit interviews, and we interview about 2,000 health workers. So it's the largest health facility survey that anywhere, and we do it every year. And we developed this scorecard, basically pulling together providers, NGOs, and funders, and the Ministry of Health on both what the scorecard would be and how to use it. We have to be a little innovative in how we do things because it's a very illiterate population and it's hard to get around. So this is the bakery. Those are the naan that you eat, and this is the scale, our Likert scale, the nanogram from poor to excellent. So you get a little, and actually Krishna did some work on actually verifying that this worked. And we tried a number of things before we came up with this. We tried to get sophisticated maps, as you can see on the left, but villages keep changing and moving, and so that's what it looks like on the right when you actually get there and have it to divide up the when we do our household surveys and try to find things. We end up producing this is our first scorecard in 2004. We have for each province and nationally we give them sort of a traffic light signal, red, green, or yellow, based on Afghanistan benchmarks for 29 indicators so that they can look at a glance where they are, and they've been able to follow them in each province and nationally. We follow them over time as well. Here you see outpatients increasing over time, leveling off 2010. Facilities providing delivery care increasing and then leveling off in 2010 as well. We've been able to do lots of research, use this as a laboratory for testing things like health financing types of questions and contracting. And I'm proud to say we actually have 6 doctoral dissertations that were produced out of this work in Afghanistan. And even more importantly, it's at a time when conditions are improving. Despite all you hear about the bad things in Afghanistan, which are also true, mortality seems to be improving. Now, there's a lot of uncertainty, an awful lot of uncertainty around this last estimate. But at least we know up until here that it seems to be improving. Trend is in the right direction. And, how can you argue? 7 out of 8 girls seem to be happy with it. I've also been very fortunate to be part of a Future Health Systems consortium that works around the world. Since 2005, I've been the director or research director with colleagues here and around the world, trying to generate knowledge to improve access, affordability, and quality of services. And we have some research themes that we're working on for the next 6 years. Again, partners around the world, the field sites focused in Africa and Asia. We have a good, fun team here. In this case, we brought our biostats department to help do some training on modeling when we were in Dhaka. Some of you are in the room here. In the first phase, I think very successful in terms of both publishing a lot and trying to get influence policy at national levels and to some degree internationally around thinking of health systems, around experimenting of systems, trying to improve poverty and health linkages, and also trying to understand health markets that are faced by the poor. And this is really an area where we're continuing in the second phase in terms of understanding health markets. There's a book that's going to come out in August or so, and the type of framework we have to try to understand how health markets work. And basically, we've seen a situation it's not like it was when we came or when, in Alma-Ata, when there was absolute shortage of health workers and drugs and information. And the situation now, there's a lot of drugs out there. People can get them. And there's lots of health workers. The problem is they're unregulated, they're often untrained, the drugs are irrationally used, and it's a huge problem in terms of quality, and frankly the financial costs are huge. So it's a different scenario and very much a market environment that we're working in. And with that, it means all the failures of markets that don't work well on their own and need to intervene. So we use this as a basis for some experimentation that we've been doing in Bangladesh and India and elsewhere, and as a way of understanding how they work. So first of all, this is just to show you that it's important. This is what proportion of respiratory infections are actually treated in the private sector, and this is DHS data across multiple countries. And in almost all of them, the majority of the private sector, and much of this is in drug shops, village doctors, and other quacks that are providing the services. We did, with another doctoral student, we did an evaluation that tried to review the literature around this and found that really, not surprisingly, the evidence base was quite small. A lot of effort in just trying to train, short-term training of informal providers, but that in itself didn't seem to be very successful. But what did work was when you did interventions that changed the market relationships. You changed their incentives and accountabilities and tried to combine relationships, interventions, often with training as well. So let me go to one last area that, hopefully moving from experience and research to more around conceptual issues. And this is around some of the conceptual issues in terms of how do you intervene in health systems and some of the problems we've had. I think one of the problems in global health that we've faced is sort of this fallacy of misplaced concreteness. It's really the notion that because you've been able to succeed in an intervention or a program somewhere, that you can simply copy it and do the same thing somewhere else and get similar effects. And sometimes it works, or often it works, but it doesn't always work. And that, I think, is one of the huge dangers of the way we approach things in international health. It's a problem with oversimplification. And ironically, if things are so simple, why do we spend so much time doing detailed planning that for the most part are inappropriate? We do spend a lot of time selecting the right thing to do, and that's very important. But I think that some of this has come with not enough time spending on learning actually how to implement it right. And I think part of this is a mental aspect in terms of what models that we actually use to do this. So I show this in class a lot. This is Magritte's painting, a ceci n'est pas un pipe. This is not a pipe. This is a picture of a pipe. It is a representation or a model. Just like this, the prevalence of HIV, this is not an epidemic. This is a model, a way of thinking about it. And so we need to think of models that actually reflect reality or the way systems actually work. And one of the driving models is this of William Ockham, in terms of trying to find the simplest solutions. And sometimes we do that a bit slashing too much, but it's still a good scientific principle. Einstein said, however, that you want to be as simple as possible, but not any simpler. But there is an alternative approach by the other famous philosopher, Wile E. Coyote. There are simpler ways to catch the bird, but the complicated ones kick butt. So there is an aesthetic reason to try something else as well. And in addition to complicated ways, try to look at chaos theory, and you get nice ideas here. The butterfly that in one place that flaps its wings and leads to a tornado that please yes, leads to the results somewhere else. But in fact, the theory doesn't really hold up to much of what we're doing. And in fact, a better model or a set of models really looks around complex adaptive systems, which, in fact, most biologic and social systems are actually complex adaptive systems when they involve multiple interacting parts in a changing environment. And these characteristics of complex systems are that they're adaptive. That means they learn, they can create their own structures, there's an evolutionary behavior. You can predict them, but not in great detail. They're not linear, and you get divergence. You get a lot of unintended consequences, and they require some other types of ways of thinking about it. Why this is important to health is that, some of the implications we see is that, you can intervene and have something work on a small scale or in one country or in a research setting. That doesn't mean you can simply plop it somewhere else. That, you have a community health worker program that works somewhere and you can put it in another country and expect it to work. We don't really have a whole lot of control over communities or providers. And that, really even the most simplest intervention in most cases involves complex social interactions. Sometimes, if we're lucky, we can have a small stimulus that produces a large effect, but more commonly we have big programs and we have slow or little effect at all, and regrettably unintended consequences, again, usually of the negative kind, are common. So Ligia Payne, a doctoral student, and I tried to look at the ways in which complex adaptive systems, what are the phenomena of change? We looked at it in the context of how do you scale up health services and tried to identify sort of these phenomena around sort of these feedback loops, these cascades, the scale-free networks. Well, scale-free networks has actually been seen quite a lot in the epidemiology in terms of disease transmission, but in other areas of public health, these other phenomena not very well studied. Phase transitions, path dependency in terms of you take certain decisions and you can't go back necessarily, and early decisions have a big impact on where you end up. And then again, this emergent behavior or self-organizing behavior. And so we tried to identify how this is actually quite common in health. And in fact, that complex adaptive systems theory has been around for a long time, just that we're a little slow to it in public health. So I want to give one example of something we've been doing in Uganda that I think reflects some of this. So we had Elizabeth Ekirapa, one of our partners in Uganda, has been trying to address the problem of high levels of unsafe delivery. Institutional delivery hovering in the 20-30% in rural Uganda, and yet they have high levels of antenatal care in the 80% for at least single ANC visits. Many different attempts at trying to supply things, train, build on supply side, and then educate and convince people to come and get institutional delivery, but it's been intractable for years. So what they decided to do is to listen to people. So starting off with patients, well, why didn't they want to go? Well, we can't afford the transport. When they get there, the doctors and nurses treat us like crap, and we have to pay for anything anyways, and I can't afford it. So why don't I just do it why don't I just deliver at home? The health providers are there to say, well, I can't make a living if I stay at the clinic, and there's no supplies, and there's no equipment, and so why would I do that? So we work together in terms of talking to the village leaders and the leaders in the health system. Came up with a small transport voucher to get motorcyclists to take them there, and unhelmeted motorcyclists, and then a small subsidy for the health providers through this voucher program, basically about $10 a delivery. And they organized themselves, and what happened was that the motorcycle drivers, the boda drivers, decided that they were going to go and identify every pregnant woman and make sure that they get there because they wanted their voucher. And the community leaders were very pleased with this, but they were in place to make sure, because they wanted their women to go for care, and they were going to make sure that nobody was stealing the vouchers. And so it worked very well. So what we had here was we actually had a comparison area, and we followed. And in November we started the intervention. I forgot the arrow here, and it had an immediate effect. Tripled the institutional delivery. So we don't know if this is sustainable yet, but certainly this is a type of emergent behavior by the boda drivers. The health workers also organized how they're going to keep the money, the amounts that they use for buying supplies themselves, how much they keep for themselves for extra pay, and how much they give to the general services to keep things going. So really emergent behavior by providers as well as by motorcycle drivers, and really a rapid, non-linear type of response. Hopefully we've changed the things so that demand will keep things going. And this, by the way, was part of really a fun exercise that we had. This is a special edition we have of, we're working with Makerere University to help them as they transformed into a College of Health Sciences, and trying to demonstrate their relevance to society. And we worked with our schools of nursing, medicine, and public health with their schools. And this was one of the pilot projects that we ran with them, and a lot of fun doing that. And some happy clients as well. So finally, in terms of where go forward in the future, I think what I'd like to be doing is, at least conceptually, in terms of how we do research around complex adaptive systems, is a little different from the past. So in the past, you would eventually develop your intervention or your program, try and control for confounding conditions or track them as you go along, and then look at your intended outcomes. And then usually organize it in a pretty linear or some equilibrium model that we're comfortable with. But I think in these systems, what we're trying to do is really look at the interaction between a program or intervention and how that changes over time, and how really these initiating conditions, these context changes, so how health providers, how diseases, how health workers, how they're related to each other. Because these concepts of connectedness, dependence, and learning, that's what actually drives the complex behaviors. Those are the types of things that we need to measure in the future, and as well measure the unintended consequences in addition to the intended consequences, and using additional models that look at more complex rates of, or complex behaviors of change than in the past. And I think this is important, not just for looking at health services as we're doing in some countries, but also how health policy changes and relationships between poverty and health and environment and health, again using these types of models. So where this tells us from CAS is that, where I think it'll contribute is how we understand disease transmission, how we understand services, and determinants as well as unintended consequences, but provide us some new tools and approaches to decision making, including how to look for phase transition, reaching marginalized groups, and tipping points in terms of really being able to take up different services and innovations. And of course, there's other kinds of theoretical implications of CAS. You need flexible planning and dynamic profit. This must be sounding like a broken record now. But again, the type of management approach to complex systems is frequent cycles of adaptation, experimentation, and planning using your component parts. So what I hope this has done is that from both my experience and from the type of research that we've been doing, and now more on the theoretical side, looking at the ways in which you intervene in health systems, is that you build on what can work, the evidence-based interventions, and focus on how to implement well, involve your key stakeholders, and importantly, listening to the disadvantaged and engaging them in the process, if not providing the ownership to them, using data, disclosing outcomes, and opportunities for experimentation and learning. And maybe that's was self-evident from the beginning, but I like to think that at least it's come full circle and provides an opportunity for the future. So I'd like to thank many people who helped along the way. I've had great colleagues here and around the world. This is the picture of all the faculty in the health systems program when we had our 50th anniversary last year. I'd also like to thank my family. One boy is here, the other is pretending to play hockey. And Ben has to give up his soccer practice, sorry about that. This is also the four of us and two additional nieces along on a trip, and a random guide, I guess. And all I can say is that if the ride ahead is at least half as fun as where we came from shooting the rapids, I think we'll have a good time in the future. So thanks very much. So I think I've left very little time for questions, which was the idea.
So, David, great talk. I really like the end where you're talking about complex adaptive systems, and it just seems to me, I don't go to every class, but we don't do a very good job of teaching that to the sort of wide range of students we have here, because it's important, as you said, for so many other things. And I keep on trying to tell the president of the university how important it is to be flexible, but it doesn't work. So, I want to.
So you need a theoretical base for it.
Yeah, I need those slides. And so I want to thank Al, Dean Emeritus, for coming, and Martha Hill, Dean of the School of Nursing. And Martha, I don't know if you could hear her from the podium, but she was sort of engaged in a one-on-one dialogue with you. She was like your cheerleader while you were talking. So questions? Al, let me give you this.
It was a terrific talk. I'm just exhausted.
Yeah, me too.
I mean, it is so complex. I mean, every one of those things are so complex. And then I think of all these things working together and trying to dissect them the way you're doing is terrific. And it's a great start that you've made. I'm going to ask one question. So have you gotten involved with the APOC program, or the African program for onco? APOC? Because that's a place where, just as you pointed out, it's community-based, and it goes across 17 nations, and it's the local communities that drive and run it, and they've had to adopt because they're all different, obviously, but covering, maybe 20, 30 million people now.
Yeah, no, I had a small involvement of that when I first came here, when Gil Burnham was actually leading an evaluation of the onchocerciasis program. And so we were looking at actually, how it works as a consortium, because it brings in lots of partners at international, national, and local levels. And so my involvement is a little old and dated, but very impressive in terms of being able to turn around on a dime, really, at local levels, but also because they set up systems where they communicate well and try and meet the needs of different stakeholders. And I think that's an important thing that we often forget, because we focus on just a few stakeholders that frankly are either most immediate or that we think are most important.
So give the mic, Bill.
David.
Sorry.
David, thanks for this talk. What you've been doing is applicable outside of low and middle income countries, and have you thought about moving into wealthier countries, and why do we have to put you in an international health department and say, David, only the poor and middle income countries? What you're doing could branch out, and would you think about doing that?
I like to think that knowledge is generalizable, but I choose to be in the Department of International Health because I believe in the mission, and it's about addressing disadvantaged people, and of course there's disadvantaged people right here in Baltimore down the street, but this is an opportunity, one of the few places in the world where you can focus really on that international and global endeavor, and that's what interests me. And I it's not that there isn't enough work here, but there's certainly enough overseas as well. Now, if they start getting better hockey teams, then I'm never going to be.
Terrific talk, David. I was struck that it seemed like part of the struggle, if you will, is that often the policies based on evidence are formed at one level, but the responsibility for implementation is at another level, and that there's a disconnect between the policy formation groups and the implementation groups. And I'm just wondering if that's one of the themes or potentially part of the package of solutions that you could use to improve implementation, is to involve implementers much more early in the formation of the policy process.
Yeah, no, absolutely. And I would go beyond formation. If you think of policy implementation is really the much more important part. And being able to bring in, both have that important, top-down policymaker approach, as well as the implementer, and frankly the beneficiary communities as well need to be involved. And I actually think that that's a role for facilitation that groups like facilitators like research and what we do actually can play that kind of bridging role, as well as, there's many other groups, there's also all kinds of policy advocacy groups and other interest groups that can play that kind of role as well. But I think that that's one of the beauties of being able to use information and being able to get people to produce their own information can play that role, but sometimes you need to get them into the same room. But no, I agree.
Thank you, David. That was a great talk. First of all, you got to get helmets on the heads of those boda drivers.
Yeah. But we're okay here, though.
That's agenda number one.
This is a very safe.
This is great.
This is very safe. Yeah.
The earliest slide. Yeah.
Yeah.
But more importantly, David, don't you think the discourse needs to be about complex adaptive systems beyond health systems, but rather the production of health? In the field that I operate, where we are talking about health production through injury prevention, for example, the health system is only one player, and sometimes a minor player. The transport system, the sector operates strongly. The police sector operates. I think your framework of CAS can be extremely useful because we are building up the complexity. And if these frameworks are helpful, they will even be more helpful, I hope, in situations where we are producing health well beyond the health system itself. So just some reflections on that.
No, I think you're right. We create artificial boundaries around things all the time, and that's true with swaps as well, but also, when you think of health systems, why stop there? I think that's important, but also if you think of, what are the really critical conditions? One of the things we found in our case studies was that, what affected implementation, the big changes were not from the health sector. They were the economic, the political changes that happened outside that have nothing to do with health. And that was really some of the drivers of what actually happened. And countless examples of this all the time. So yes, I think that the theory is generalizable and that we do need to look beyond. And I always think of, what Henry Moseley always talked about, even in terms of health, that actually, health begins in the home, and you should really be thinking, first of all, starting from that unit and out, and what is the household interested in? And it's a lot more than just health and health services.
Thank you very much, David. That's a great talk. Must say you leave me a bit depressed. The family itself is a complex system, but never mind.
And happy families are less complex than unhappy families. But anyway.
Many of the international agreements for programs state blithely, in order for this to succeed, strengthen health systems. It appears blithely strengthen health systems. There are very many distinguished persons like the head of the World Bank and other distinguished people get together and write a brochure, how to strengthen health systems. You must be smiling when you see these kinds of naive, sort of platitudinous approaches, strengthen health systems.
Well, I'm smiling anyway.
Because it's really fatuous, according to what you say. You can't really say strengthen health systems globally. You got to say strengthen A, B, C, D.
No, they're very much context specific, and I think that we're right now riding a wave where people are interested in strengthening health systems really as a delivery vehicle, but also out of recognition that, you need things to sustain beyond, particular project funding, which is what we do so well. But, it really is, when you're strengthening systems, it's not a project. That's sort of like a lifelong type of commitment for, that's what ministries of health are supposed to be doing. And you have to, you never get out of it in terms of the responsibility. So it's, if it's exhausting just thinking about it, it should be even, I think energizing to try and just keep working on it. Whether there's going to be a fund for health systems or, this is not a particularly good idea, but I think we need to challenge ourselves to, whatever the approach du jour is, to think of, what is the long-term game plan for how things are going to be working. And that's where systems thinking and health systems is critical.
So it's great that you're holding the audience. It's past time, but we have, let's have two more questions, if that's okay with you. So first, Chris.
Well, let me add my thanks to everybody else.
I may have turned it off. Is that all?
I could hear you. So.
Okay, good. And let me also just say it's great for you to, I think, to begin and end on models and thinking about some of the philosophical underpinnings of what we do, because I think we don't do enough of that, and it's really very helpful. At the risk of being a Burma bore, couldn't help but think about your complex adaptive systems in the context of a place like Burma, where people have operated in a profoundly dysfunctional system and then have developed adaptations to, you know, things like vertical rule and control from central sectors that really don't have population's best interests at heart. And how you begin to operationalize reform to get out of a complex maladaptive system.
Right.
Now, it's a
Well, I
it's a
mean,
difficult
it's. I mean, I think a number of strategies for how to do this, but basically, you have to work side by side with who you think your key stakeholders are at local level, your beneficiaries, and who's now responsible for making things happen, and try and probably pick some few areas where you can get some successes. But I think you also have to have a more concerted effort of trying to find how people have been so incredibly resilient. How do people survive under these conditions, and what do they learn as a result of that? I think that you need to see that at the community level in a concerted way, starting with listening to what's happened and how they plan to, or have been able to survive and move forward. But there's also an awful lot of learning that has to happen in public institutions. And how do you regain trust in public institutions? I think part of it is actually by providing basic services that people can start gaining a trust in that. And it's a long time, whether that goes in line with, what happens with reconciliation and other peace building types of efforts, I don't know. But I think within the health sector, you can look to try to at least gain some trust around providing basic services, and hope that you can learn along with the other sectors as well.
And then last question.
I would really like to add my congratulations on a wonderful talk. And as you were talking, I was beginning to think of what the role of anthropology and anthropologists are. I wonder, I've made lots and lots of mistakes, and I think it's because I'm middle class. And is it possible for someone that's middle class, that has a value set, to understand the poor and design programs for the poor without really understanding them and their behavior and how they carry on? And I see, academics and major people designing programs which are naive and completely ineffective, including ones I've done myself. It's because we don't understand how the poor behave and the networks they have and how they survive. And they're really extremely skillful. If I was given the resources of a poor person in Angola, there's no way I would survive, and yet these people do survive. And I think we really have to involve the poor, involve the disadvantaged in designing all these programs. I would love your comments on that.
Well, I mean, I agree entirely. I think that, that you have to start with, the best we can do is listen and try to find ways of facilitating ways to empower and to ensure that services and that the resources that are and opportunities are made available for disadvantaged people. Now, and whether we can ever understand that, probably not. I don't really know, but we can. It's incumbent upon us to do our best to try and to bring the type of resources that we have, whether they be at the policy level, whether it be financing, or whether it be trying systems that, I think accountability to the poor is a big part of it. Not just having them have the physical and financial resources, but actually ensuring that information and that other kinds of accountability are open, and that those are things that can be done by policymakers at central level and by researchers, and we can move in that direction. But I think that the thing is that you don't have sort of pat answers for how to do that, because you can have your intentions, but I think all the way along you have to continually learn how to keep doing it better. And the organizations that succeed at that, whether they be people's movements or otherwise, are those that continue to learn and continue to listen to stakeholders, and I think that's critical.
Thanks, Dave.
You're listening to your stomach now.
No.